تفضل.
Thank you, Dr. Abdullah, for the invitation. Good evening, everybody. So I think we've gone through the acute phase, and my task is to see how can we manage those patients in the pre-discharge and post-discharge, and mainly medication-wise. This is the journey for heart failure patients. It's really quite tasking from the acute to the discharge, chronic, and coming back again to the hospital. And every time they come back with admission, they get more mortality. So it's really a very progressive disease and intercepts. I mean, it's a downhill trend, and always having interception with the, with the acute phases, and of course, losing functionality and increasing mortality. I think we've been extremely good in the last decade or so by identifying mechanisms and target of medication. And this is a list, and I think maybe I missed one or two still, between the norepinephrine to aldosterone to angiotensin 2, neprilysin, SGLT2, the newer cyclic GMP. So these are all medications that added to the armamentarium that we have. But despite that, there's still residual risk. I mean, as you can see, we improve a lot, and as far as EF and survival, but there's still more, and that's why it's a very progressive disease. And this is what we have, and I think it's always difficult to decide. I mean, you have the Fantastic Four and the other medication that helps while we appreciate this. So worsening heart failure, and it's interesting how the guideline has really focused on this issue, because the problem in the hospital is really those patients, because you really have to start from scratch. You may stop everything and then reinitiate depending on the patient clinical syndrome. So it's a progressive sign and symptoms where the guided medical therapy has not worked, and therefore you have to restart, and usually they are quite congested, and therefore IV diuretics is a key element in those patients to define worsening heart failure. So, as I say, the mortality increases as patients get readmitted, and they lose more myocardium as they get readmitted to the hospital. And it doesn't matter whether they are taken care of in the emergency department, the outpatient. Many of my patients come to the outpatient, and they don't want to get admitted unless they're really in a dire strait, but therefore you initiate IV therapy sometimes as an outpatient. So in the acute phase being talked about earlier, this is where really hemodynamically the patient is in a very unstable situation. And the congestion is a critical element for the patient. They come either with frank pulmonary edema, or they come plainly short of breath due to congestion. So the majority of patients come with congestion and hypoperfusion, or without hypoperfusion. And therefore, IV Lasix becomes a critical concept here. So we have three therapeutic interventions. First of all, you need to focus on the decongestion, and this is in the acute phase. I'm not going to touch on this. And then focus on the guideline medication that we have. We start initiating them. Because as I say, maybe we have to stop all the medication and we start again, and subsequently optimize before the patient leaves the hospital, because this is a golden time for this. So this is the congestion, diuretics, inotrope, dilator, and patient may improve, may not improve. And I think this is a very volatile sort of time. And I think the issue here is when patients are stable and they are on oral medication, then you have to start thinking. For me, when patients sit up and they start eating, this is where I start looking into the orals. But there are certain caveats that we need to look at, because most of the heart failure medication are hypotensive. They all reduce blood pressure. So you need to have, and I think blood pressure is key. So at least systolic blood pressure above 100 in the last 6 hours. No increase in IV diuretics, and maybe it's even a decrease. No IV vasodilators, no inotropes. Key element is eGFR and heart rate. This is a list of all the trials that have been done in acute or worsening heart failure. The four top one are to do with SGLT2 inhibitors. 3 of them are published, 1 is not yet. We have the Galactic heart failure, Victoria for worsening heart failure, and the Pioneer, and I think I have one more. Anyway, these are to do with ARNI, the Paradise. I think this is the other one. So I think Dr. Rosano has expanded on the SGLT2 inhibitors, and this is the spectrum. I don't think there's any medication have shown to work in preserve, reduce through the whole spectrum of EF in the outpatient and in inpatient. This is quite an impressive. Unfortunately, many cardiologists still view this medication as anti-diabetic medication. But I think this has evolved significantly. Impulse, and it's been touched on earlier, it's one of those really trials that really focuses on those patients who come in with acute heart failure. Randomizing IMPA-10 to placebo versus about 90 days. And this has been shown before. All the clinical benefit is in favor of empagliflozin. Now, this is of interest. This was published last month in the European Society of Cardiology Heart Failure. It's an extension on the IMPULSE trial, looking at the congestive parameters. And I think this diuretic effect of the SGLT2 inhibitors comes very handy in those patients. So these look at the congestive parameters from weight loss to change in the enzyme, to hemoconcentration, to clinical congestion score, dyspnea. And it really seems that this is a perfect medication in those patients who have just gone out of acute phase, and you can initiate this to support even. I very much reduce sometimes the diuretics and add the SGLT2, and you get a very good diuresis on top of what you have with the Lasix, and subsequently you can reduce the Lasix. And as you can see here, there's a significant drop in the weight. Weight is water in those patients. Again, this is looking at the congestion score, where you look at dyspnea, orthopnea, fatigue. Again, it's significant at day 15 as maintained through the 90 days. So I think it's really, to my mind, we need to use more of these medication. And I think, to my practice, this is, except you have to be careful. The patient's diabetic, they're not eating, so you have to be careful with the DKA. Sometimes it may happen. But in non-diabetic, there's no issue whatsoever. So the IMPULSE trial here, there's an early clinical meaningful and sustainable decongestion. This is beyond, on top of the outcome benefit that you talked about and we heard about. There's a greater change in the markers of congestion over time, the 3 issues. And this decongestion is associated with clinical benefit. I mean, you give Lasix, it doesn't impact outcome. It just reduces fluid. No, here you decongest and improve outcome. What about ARNI? There's a couple of studies. Pioneer, small number, looking at the NT-proBNP. There's a SANAT outcome, and you can see there's significant improvement with the ARNI as far as comparison to the ACE inhibitor. The Paradise, which I touched on earlier, this is a big trial, looking at 5,000 patients with acute MI, admitted with acute MI. So this is a true acute study. And they have pulmonary congestion, low EF, randomized to ramipril versus ARNI. And as you can see, there was no benefit as far as cumulative outcome between ramipril and the ARNI. On top of this, there was significant impact on high blood pressure. ARNI produces more hypotension, low blood pressure than the parameters. So that's really the question I'm thinking as far as the order of things when we talk about patients who are just recovering from the acute phase and blood pressure is significant. Victoria is an interesting trial. I think it's being given the grading is not as good, but the patient in Victoria are very sick patients, and I really appreciate the trial because these are the patients that we deal with, and it would be nice to see a trial that addresses those patients. These have class 2 to 4, EF less than 45, PROM-P more than 1,000, EFR, EGFR, so it's very low EGFR. So these are these very sick patients. Yet there was some significance as far as the composite outcome, but there was no cardiovascular outcome benefit. I think Versigua can be quite helpful when you have an issue with renal function, with potassium, and heart rate, because it's neutral. Yes, it has some effect on blood pressure, but it's mild. So the last point is the optimization, and this is key. The European guideline put the 4 medication equally, which I think is a great idea, because then you can decide as per your clinical scenario. Well, the American guideline just slumped Arnil as a start off with beta blocker, and then I don't think this is a good concept when you have patients who have labile blood pressure. So eventually we need to optimize to transit patient to the clinical care. And this is the dilemma, what to start first and what to start next. And I really think, again, that you need to think of 4 components or 5 and make a decision. Blood pressure, renal function, heart rate, and potassium. And blood pressure is key. This is one paper, this is looking at the 200 about hospitals in the US, looking at the impact of low blood pressure on admission for patients with heart failure. And there's a direct correlation between mortality and low blood pressure. And I think we tend to over titrate these medications. I think you should take your time, because at the end of the day, you don't want to have the patient to decompensate again. And again, you see there are some trials where there is a low systolic blood pressure is correlating to higher mortality. And I'd like to stick with the way I look at the optimization of medication is this paper written by John McMurray and Melton Packer, where they suggested to start beta blocker and SGLT2. And I personally would start with SGLT2 as a prime medication in those patients. If you have blood pressure, I don't think I have any issue with ARNI being started at small dose and maybe titrated, and the last one to have the MRA. So really, it's a choice that is determined. We would like to accelerate these medication, but we have to have in mind that there are priority phenotyping the patient, saying what is the predominant mechanism that we can deal with. Thank you very much.